Good afternoon. Today I would like to introduce you the next pharmacology lecture, Drugs Acting on Central Nervous System, Part 1. Lecture plan: General anesthetics, ethyl and methyl alcohols. Let's start from general anesthetics. First of all, the reminder about nervous system. As you remember, nervous system is divided into central nervous system and peripheral nervous system. In this and few more coming lectures, we will talk about those drugs which are acting on central nervous system. General anesthesia or narcosis, from the Greek narcosis, numbness, rigidity. General reversible depression of the central nervous system such that perception of all senses is ablated. It is characterized by the loss of consciousness, pain feelings, depression of reflexes, and relaxation of skeletal muscles, and which is obtained by the administration of drugs for general anesthesia. On this picture you can see first public demonstration of ether administration for excision of neck mass in 1846. Dr. Morton administered ether anesthesia using a glass bulb filled with ether-soaked gauze. And on the same day appeared the very famous phrase, "Gentlemen, this is no humbug." General anesthesia is one of the greatest discoveries in medicine of all time. Made modern surgery possible, rare to go through life without being anesthetized at least once, but it is scary, low therapeutic index, unknown mechanism of action. Unitary hypothesis. General anesthesia can be caused by a remarkable number of structurally diverse molecules. For example, you can see them on the left side. Molecules have different size, chemical properties, suggest single-site common mechanism. Classification of modern general anesthetics. They are classified into inhalational, first of all, which are subdivided into gases and volatile liquids. Gases, as an example, nitrous oxide. Volatile liquids, for example, ether, halotan, isofluran, desfluran, sevofluran. And intravenous, which are subdivided into fast-acting drugs, for example, thiopentone sodium, methotrexate sodium, propofol, etomidate, sodium oxybutyrate, propanidite. Propanidite is withdrawn from the market due to frequent anaphylactic reactions, but still present in some countries. And other group of intravenous ones, slow-acting drugs, which are subdivided into benzodiazepines, for example, diazepam, lorazepam, midazolam, dissociative anesthesia, for example, ketamine, and opioid analgesia, for example, fentanyl. Characteristics of modern general anesthetics. Most anesthetic procedures today involve the combination of different anesthetic drugs which are being used in concentrations that are considerably smaller than those needed if the drug were to be used all by itself. Halogenated anesthetics, for example, sevofluran and desfluran, have got rapid and pleasant induction and recovery from anesthesia, rapid changes in the depth of anesthesia, adequate relaxation of skeletal muscles, the absence of toxic effects or other adverse properties in normal doses, a wide margin of safety. Advantages of using intravenous drugs, thiopentone sodium, propofol, sodium oxybutyrate as an examples, high potency and rapid reversibility, adds flexibility and permits the administration of lower doses of inhalational drugs, permit more precise control of the effect required. Site of action of general anesthetics. The difficulty to determine the site of action in the CNS for general anesthetics. We have no consensus of opinion regarding the region or regions of the brain responsible for the maintenance of consciousness. The brain area responsible for the control of consciousness. Cerebral cortex? No. Large regions of the cortex could be ablated without loss of consciousness. Brain stem? Also no. Although much data exists on anesthetic effects in various brain regions, no set is sufficiently complete or consistent to allow one to conclude that exert their actions through one specific effect in one CNS region. Since it's difficult to define general anesthetics comprehensively and quantitatively, there has been from the beginning a search for in vivo and in vitro model systems capable to either reflect general anesthetics completely, to describe partial aspects of it, or to measure it indirectly. Effects of general anesthesia. For example, low-dose effects and high-dose effects. Low-dose effects: amnesia, euphoria, analgesia, hypnosis, excitation, hyperreflexia. High-dose effects: deep sedation, muscle relaxation, diminished motor responses, diminished autonomic responses, myocardial protection from ischemia, cardiovascular respiratory depression, hypothermia. Let's talk a little about measures of anesthetic potency. MAC, minimum alveolar concentration. MAC is the concentration of anesthetic that produces immobility in 50% of patients exposed to a noxious stimulus. MAC awake. MAC at which response to commands are lost. Amnesia, loss of awareness. MAC-BAR, blunt autonomic response. MAC intubation, response to intubation. Besides conventional EC50 for the drug potency measurement, MAC is more popularly used in this field. And in here I would like you to take a look at general anesthetics, stages of anesthesia. Physiological changes during stages of general anesthesia with ether. In simple, from 1 to 4, as you see stages, the concentration of general anesthetic is increasing. So, for example, you have put a mask on the patient and started the administration of ether. And the more concentration is increasing, the more patient is going through those stages: 1, 2, 3, and 4. The first stage is analgesia, second stage delirium, third stage surgical anesthesia, which is subdivided into 4 planes or 4 levels, and fourth, medullary paralysis. Also, you can see what is happening with different functional organs and body functions of that specific patient. For example, on stage 1, you can see respiration, how it is, ocular movement, pupil size, reflexes, skeletal muscle tone, blood pressure, heart rate, and uses. Stage 1 is characterized specifically with the loss of pain sensation. So patient doesn't feel pain. He is conscious, but depression of consciousness is provided. No major operations are done in this stage, but, for example, it can be some kind of minor operations or minor uses. Labor, incisions, and minor operations, as you can see on the right side. Second stage, delirium. It starts from the loss of consciousness of the patient, and it is very unstable. None of uses are in this case. Patient is unstable, respiration unstable, heart rate, blood pressure, skeletal muscle tone, as you can see. And always we are trying to prevent this second stage, which is delirium. Patient is talking, patient is very excited, and we aren't doing any kind of operations in second stage. Third stage, surgical anesthesia, which is divided into 4 levels or 4 planes: 1, 2, 3, and 4. And also you can see the representation how the CNS inhibition is provided in this stage. Most of surgical operations are done in first, second, up to the middle of third level of surgical anesthesia stage. Fourth level, it is the risky one because it is very close to the overdose. And stage 4 is medullary paralysis. So you can see that all the functions are inhibited and the state of the patient is critical. It can cause death. So once again, your mission is to keep the patient in stage 3 in levels from 1 till the middle of third one for most surgical operations. Surgical interventions are performed on first and second levels, approximately till half of third level of third stage of anesthesia. Please remember this. So let's talk now in details about drugs for inhalation anesthesia. First representative is nitrous oxide. Small power and width of narcosis action, stage of excitation, yes, second stage, is present, quick entry and exit from narcosis, 1-2 minutes. Colorless, odorless, heavier than air, non-inflammable gas, supplied under pressure. Non-irritating, low-potency anesthetic. Unconsciousness cannot be produced in all individuals without concomitant hypoxia. Patients maintained on 70% nitrous oxide plus 30% oxygen, along with muscle relaxants, often recall the events during anesthesia, but some lose awareness completely. Good analgesic. Even 20% produce analgesia equivalent to that produced by conventional dose of morphine. Muscle relaxation is minimal, used as a carrier and adjuvant to the other anesthetics. Uses as an analgesic: pregnancy, teeth extraction, bandaging in case of burns, cleaning and revisions of wounds, ischemic heart attacks and myocardium infarction, colic, traumas, acute pancreatitis, pain relief in post-operative period. The next representative is ether, diethyl ether, about which we talked before. It is highly volatile liquid, produce irritating vapors which are inflammable and explosive, produce good analgesia and marked muscle relaxation by reducing acetylcholine output from motor nerve endings. The dose of competitive neuromuscular blockers should be reduced to about 1/3. It is highly soluble in blood. Induction is prolonged and unpleasant with struggling, breath holding, salivation, and marked respiratory secretion. Atropine must be given. Recovery is slow. Post-anesthetic nausea, vomiting, and retching are marked. The next is halotan. Halotan is volatile liquid with sweet odor, non-irritant and non-inflammable. Solubility in blood is intermediate. Induction is reasonable, quick, and pleasant. Potent anesthetic. Precise control of administered concentration is essential. Causes relatively great depression of respiration. Urine formation is decreased during halotan anesthesia due to fall in blood pressure. Power of anesthetic action of halotan is higher than ether. It has a large width of narcotic action, doesn't irritate mucous membranes of breath tracts, doesn't cause laryngeal and bronchial spasm, speed of development of narcosis 3-5 minutes. After narcosis, depression is not expressed. Side effects and complications: hypotension and cardiac arrest, sensitization, increased sensitivity of myocardium towards catecholamines, acute damage of liver, halotan hepatitis, and teratogenic action. Next one is isoflurane. Isoflurane introduced in 1981. Currently routinely used overall. Magnitude of fall in blood pressure is similar to halotan due to vasodilation, probably of beta adrenoreceptor stimulation, while cardiac output is well maintained. Desflurane. Desflurane, newer fluorinated congener of isoflurane, 5 times less potent than isoflurane. Sevoflurane. Sevoflurane, new polyfluorinated anesthetic, has properties intermediate between isoflurane and desflurane. Sevoflurane doesn't cause sympathomimetic stimulation and airway irritation even during rapid induction. Fall in blood pressure is due to vasodilation as well as modest cardiac depression. And anesthetic of the future, xenon. Rare gas extracted from air, very expensive to produce, close to ideal anesthetic, low blood and tissue solubility, rapid induction recovery, potent, not metabolized, non-flammable, minimal side effects. Now we came to the part of drugs for intravenous anesthesia. First representative is thiopental sodium. After administration of the drug, narcosis develops in 1–2 minutes. Awakening occurs in 20–30 minutes. Uses of thiopental sodium. Introduction narcosis, basis narcosis, mononarcosis in case of short-lasting operative interventions, for example in dentistry, gynecology, traumatology, anti-seizure drug. Side effects: cough, laryngeal and bronchial spasm. In case of rapid introduction, depression of centers of medulla oblongata. In case of contact of the drug with skin, its separation may occur, contact with nervous trunk or near it, irreversible paralysis, contact with an artery, thrombosis with the following gangrene of the extremity. On this slide you can see the pictures of thiopental sodium in its drug form. Next one is propanidine. Narcosis develops after 30–40 seconds from the beginning of intravenous introduction of the drug, on the edge of the needle as they call it. Stage of surgical narcosis lasts for 3–4 minutes. Uses: for mononarcosis during short operative interventions in surgery, dentistry, gynecology, urology, painful diagnostic procedures, sometimes for introduction into narcosis. Side effects and complications: frequent breathing, tachypnea, with the following stopping of breathing, apnea, phlebitis and thrombosis in the place of introduction, and anaphylactic reactions. Due to anaphylactic reactions, this drug is withdrawn from the market, but still present in some countries. The next one is sodium oxybutyrate. In case of intravenous introduction, narcosis develops after 15–40 minutes. If administered orally, after 30–60 minutes, and duration of narcosis is 1.5 to 3 hours. It manifests anti-hypoxic properties. Uses: mononarcosis, to perform long-lasting surgeries but with small traumatic effect, premedication, introduction and basis narcosis, drug of choice for narcosis in case of intoxications, sepsis, disturbance of functions of parenchymatous organs, analgesia during child delivery, to decrease psychomotor excitation, seizures, insomnia. Side effects: motor excitation, seizure twitching of extremities and tongue, vomiting, hypopotassiemia or hypokalemia. Next one is propofol and its trade name Diprivan. Drug with ultra short action. Narcosis develops after 30–40 seconds after intravenous introduction, lasts for 3–5 minutes. Uses: mononarcosis, polycomponent narcosis, artificial ventilation of lungs. Positive features: can't be accumulated, doesn't have after narcosis depression, possesses anti-vomiting action. Negative features: doesn't have analgesic action. It is often combined with fentanyl or ketamine. Possible hypotension, short apnea. And on this slide you can see pictures of propofol in its drug form. Next one is ketamine hydrochloride. Trade names Ketalar, Calypsol. During intravenous introduction of the drug, narcosis develops after 15-30 seconds, lasts for 8-10 minutes. During intramuscular introduction, after 2-3 minutes, lasts for 20-30 minutes. Uses: introduction and basis narcosis, mononarcosis during surgeries which don't need muscular relaxation, as a part of combined narcosis. Side effects: during coming out of narcosis, unpleasant dreams, delirium, hallucination, seizures, nausea, vomiting, increasing in blood pressure, increasing of frequency and power of heart contractions. Please remember these hallucinations because they are more specific to ketamine hydrochloride. The drug is able to raise intracranial pressure, oxygen consumption by brain, and intraocular pressure. And on this slide you can see the picture of ketamine hydrochloride, for example, Ketacet as the trade name in its drug form. And on this slide you can see physical and anesthetic properties of inhalational anesthetics. For example, ether, halotan, isofluran, desfluran, sevofluran, and nitrous oxide. Their anesthetic, boiling point, inflammability, irritancy, oil gas partition coefficient, blood gas partition coefficient, minimum alveolar concentration, induction, and muscle relaxation. And in here, effects of intravenous anesthetics on vital functions. For example, thiopentone, propofol, etomidate, diazepam, ketamine, fentanyl, on heart rate, blood pressure, respiration, and cerebral blood flow. One more very important part in the complex of general anesthesia, pre-anesthetic medication or pre-medication. Pre-anesthetic medication refers to the use of drugs before anesthesia to make it more pleasant and safe. The aims are relief of anxiety and apprehension preoperatively and to facilitate smooth induction, amnesia for pre- and post-operative events, supplement analgesic action of anesthetics and potentiate them so that less anesthetic needed, decrease secretion and vagal stimulation that may be caused by the anesthetic, antiemetic effect extending to the post-operative period, decrease acidity and volume of gastric juice so that it is less damaging if aspirated. So, which pharmacological groups can be used for premedication? For example, sedative anti-anxiety drugs, benzodiazepines, diazepam 5-10 mg oral, lorazepam 2 mg oral or 0.05 mg/kg intramuscular 1 hour before, midazolam, and promethazine 50 mg intramuscular. Opioids, morphine 10 mg intramuscular, petidine 50 to 100 mg intramuscular. Disadvantages: they depress respiration, interfere with pupillary signs of anesthesia, may cause fall in blood pressure during anesthesia, can precipitate asthma, and tend to delay recovery. Anticholinergics: atropine 0.6 mg or 10-20 micrograms kilogram IM IV, hyoscine 0.6 mg or 10-20 micrograms kilogram IM IV, and glycopyrrolate 0.2-0.3 mg or 5-10 micrograms kilogram IM IV are used primarily to reduce salivary and bronchial secretion. Now this is infrequent due to the use of non-irritant anesthetics. The main aim of their use now is to prevent vagal bradycardia and hypotension, which occur reflexively due to certain surgical procedures, also for prevention of some manifestation. And below you can see the comparison between atropine and glycopyrrolate in actions: anti-secretory, tachycardia, CNS effects, bronchodilation. Fourth, neuroleptics, for example, chlorpromazine. Fifth, histamine 2 receptors blockers and proton pump inhibitors, for example, ranitidine, famotidine, omeprazole, pantoprazole. And six, antiemetics, metoclopramide, domperidone, ondansetron. The next part of our lecture is ethyl and methyl alcohols. Ethyl alcohol or ethanol. Alcohols are hydroxy derivatives of aliphatic hydrocarbons. Usually alcohol refers to ethyl alcohol or ethanol, manufactured by fermentation of sugars. Glucose, with the help of zymaze in yeast, is forming carbon dioxide and ethanol. Fermentation proceeds till alcohol content reach around 15%. Then the reaction is inhibited by alcohol itself. Starchy cereals, for example barley, when soaked, produce malt. Starch, with the help of convertase, produce maltose, which can then be fermented by yeast to produce alcohol. Ethyl alcohol beverages. Malted liquors obtained by fermentation of germinating cereals are undistilled, beers, stout, etc. Alcohol content is low, 3–6%. Wines, produced by fermentation of natural sugars which are present in fruits, grapes, apple, plum, etc., are undistilled. They are subdivided into light wines, fortified wines, and effervescent wines. About them, read later on the slide if you are interested. And spirits are distilled after fermentation: rum, gin, whiskey, brandy, vodka, etc. Alcohol content can vary from 40 to 70%. Other forms of ethyl alcohol are absolute alcohol, 99% weight per weight ethanol, dehydrated alcohol, rectified spirit, 90% ethyl alcohol produced from fermented molasse by distillation, proof spirit, which is an old term. If poured on gunpowder and ignited and it explodes, then it was labeled to be of proof strength. If water is mixed to it, gunpowder will not ignite. Usually 100% proof spirit is 49,29% weight per weight, or 57.1 volume per volume alcohol. And methylated spirit, industrial, also called denaturated spirit, is produced by adding 5 parts of wood naphtha, methyl alcohol, to 95 parts of rectified spirit, so as to render it unfit for drinking. It is tinted blue by methylene blue dye for distinction. Can be applied on the skin for antiseptic, cleaning, and astringent purposes. And below you can see the description of volume per volume, weight per volume, and weight per weight. Pharmacological action of ethyl alcohol. Local action is a mild rubefacient and counter-irritant when rubbed on the skin. CNS is a neuronal depressant. CDS depend on dose. Blood, moderate doses has been found to raise high-density lipoprotein cholesterol levels and decrease low-density lipoprotein oxidation. Body temperature is reputed to combat cold, but high doses depress temperature regulation. Respiration, direct action on respiratory center is only a depressant. GIT, variable effects. Liver, cause liver damage. Skeletal muscle, weakness and myopathy occurs in chronic alcoholism. Kidney diuresis is often noticed after alcohol intake. Sexual function reputed as aphrodisiac, but chronic alcoholism can produce impotence, testicular atrophy, gynecomastia, and infertility in both men and women. Endocrine effects: moderate amounts increase adrenaline release, which cause hyperglycemia and other sympathetic effects. Pharmacokinetics of ethyl alcohol. Rate of alcohol absorption from stomach is dependent on its concentration, presence of food, and other factors, but is generally quite slow. Absorption from intestines is very fast. Peak levels are attained after 30 minutes around. Thus, gastric emptying determines rate of absorption. Limited first-pass metabolism occurs in stomach and liver. Alcohol gets distributed widely in the body, efficiently crosses blood-brain barrier, concentration in brain near blood concentration, freely crosses placenta. Alcohol is oxidized in liver to the extent of 98%. You can see in here that alcohol, with the help of alcohol dehydrogenase, forms acetaldehyde, which after that, with the help of aldehyde dehydrogenase, forms acetate, and acetate is forming at the end carbon dioxide and water. We will come back to this metabolism a little later on. Even with high doses, not more than 10% escapes metabolism. In addition to alcohol dehydrogenase, small amounts as well are oxidized by hepatic microsomal enzymes, mainly CYP2E1. Metabolism of alcohol follows zero-order kinetics. Constant amount, 8-12 milliliters of absolute alcohol hour, is degraded in unit time, irrespective of blood concentration. Thus, rate of consuming drinks governs whether a person will drink. Excretion of alcohol occurs through kidney and lungs, but neither is quantitative significant. Concentration in exhaled air is about 0.05% of blood concentration. Thus is utilized for medical legal determination of drunken state. Interactions. Alcohol synergizes with anxiolytics, antidepressants, antihistamines, hypnotics, opioids. Marked CNS depression with motor impairment can occur. When metronidazole, sulfonylurea, or cefoperazone is taken, bizarre, somewhat disulfiram-like reactions can occur when person consume alcohol simultaneously. The reaction is not obligatory. To disulfiram we will come little later on. Acute alcohol ingestion inhibits, while chronic intake induces CYP enzymes, especially CYP2E1. Formation of toxic metabolite of paracetamol is increased in chronic alcoholics. Safe dose limit of paracetamol is lower in them. Metabolism of tolbutamide, phenytoin, and some other drugs is similar affected by acute and chronic alcohol intake. Hypoglycemic action of insulin and sulfonylureas is enhanced by alcohol ingestion. Aspirin and other non-steroidal anti-inflammatory drugs cause more gastric bleeding when taken with alcohol. Food value of ethyl alcohol. Alcohol requires no digestion and is metabolized rapidly. It is an energy yield substrate, 7 calories each gram. For comparison, there are 9 calories in a gram of fat, but alcohol ones cannot be stored. However, it spares carbohydrates and fats as energy source, so that regular intake can contribute to obesity. Alcohol doesn't supply bodybuilding and other essential constituents of food. Those who consume substantial part of their caloric intake as alcohol often suffer from nutritional deficiencies. Thus, alcohol is an imperfect and expensive food. Contraindications: Alcohol is seldom prescribed medically. Intake of alcohol should be avoided by peptic ulcer, hyperacidity, and gastroesophageal reflux patients. Alcohol increase gastric secretion and relax lower esophageal sphincter. Epileptics, seizures may be precipitated. Severe liver disease patients. Unstable personalities, they are likely to abuse it and become excessive drinkers. Pregnant women, even moderate drinking during pregnancy can produce fetal alcohol syndrome, resulting in intrauterine and postnatal growth retardation, low IQ, microcephaly, craniofacial and other abnormalities, and immunological impairment. Guidelines for safe drinking. Various official agencies, physician organizations, and alcoholism experts have put forth guidelines in this regard, but they are not uniform. On an average, 1-2 drinks per day is usually safe. Not more than 3 drinks on one occasion. Consumption of more than 3 drinks per day is associated with documented adverse health effects. Do not drive or engage in hazardous activities after drinking. Do not drink if an interacting drug has been taken. Subjects with any contraindication should not drink. Safe limits are somewhat lower for women than for men because the metabolism of alcohol is slower and bioavailability is higher due to less first-pass metabolism in stomach in women than in men. And now we came back to the point of metabolism of ethanol and one very important drug. To remind you, ethanol, with the help of alcohol dehydrogenase, forms acetaldehyde. After that, acetaldehyde, with the help of aldehyde dehydrogenase, is forming acetate, and after that, carbon dioxide and water. Let's stop on this acetaldehyde. Aldehyde dehydrogenase inhibitor, specifically disulfiram. It inhibits the enzyme aldehyde dehydrogenase, probably after conversion into active metabolites. When alcohol is ingested after taking disulfiram, the concentration of acetaldehyde in tissues and blood rises, and a number of highly distressing symptoms, aldehyde syndrome, are produced promptly. These are flushing, burning sensation, throbbing headache, perspiration, uneasiness, tightness in chest, dizziness, vomiting, visual disturbances, mental confusion, postural fainting, and circulatory collapse. Disulfiram aversion therapy is indicated in abstinent subjects who sincerely desire to leave this habit. The next one is methyl alcohol, or methanol, or wood alcohol. Methyl alcohol is added to industrial rectified spirit to render it unfit for drinking. It is only of toxicological importance. Mixing of methylated spirit with alcoholic beverages by bootleggers or its inadvertent ingestion results in methanol poisoning. Methyl alcohol metabolism. Methanol is metabolized to formaldehyde and formic acid by alcohol and aldehyde dehydrogenases, respectively, but the rate is 1/7 that of ethanol. Like ethanol, metabolism of methanol also follows zero-order kinetics, and half-life of 20-60 hours has been measured. And in here you can see the metabolism of methyl alcohol by the help of alcohol dehydrogenase, the formation of formaldehyde by the help of aldehyde dehydrogenase, the formation of formic acid. Actions. Methanol also is a CNS depressant, but less inebriating than ethanol. Toxic effects of methanol are largely due to formic acid, since its further metabolism is slow and folate dependent. A blood level of more than 50 mg deciliter of methanol is associated with severe poisoning. Even 15 milliliters of methanol has caused blindness and 30 milliliters has caused death. Fatal dose is regarded to be 75 to 100 milliliters. Poisoning. Manifestations of methanol poisoning are vomiting, headache, epigastric pain, uneasiness, drunkenness, disorientation, tachypnea, dyspnea, bradycardia, and hypotension. Delirium and seizures may occur and the patient may suddenly pass into coma. Acidosis is prominent and entirely due to production of formic acid. The specific toxicity of formic acid is retinal damage, blurring of vision, congestion of optic disc, followed by blindness, always precede death, which is due to respiratory failure. Treatment of methanol poisoning. Keep the patient in a quiet, dark room, protect the eyes from light. Gastric lavage with sodium bicarbonate if the patient is brought within 2 hours of ingesting methanol. Supportive measures to maintain ventilation and blood pressure should be instituted. Combat acidosis by IV sodium bicarbonate infusion. This is the most important measure. Prevents retinal damage and other symptoms. Large quantities may be needed. Potassium chloride infusion is needed only when hypokalemia occurs due to alkali therapy. Ethanol is preferentially metabolized by alcohol dehydrogenase over methanol. At a concentration of 100 mg deciliter in blood, it saturates alcohol dehydrogenase and retards methanol metabolism. Hemodialysis clears methanol as well as formate and hastens recovery. Fomepizole is a specific inhibitor of alcohol dehydrogenase and the drug of choice for methanol poisoning by retarding its metabolism. Folate therapy, calcium leucovorin 50 mg, injected 6 hourly, has been shown to reduce blood formate levels by enhancing its oxidation. And the last for today is ethylene glycol poisoning. Ethylene glycol poisoning has occurred sporadically, especially among children. It is an industrial solvent, coolant, and antifreeze. Ethylene glycol is oxidized in the body by alcohol dehydrogenase to glycolaldehyde and then to glycolic acid, glyoxylic acid, oxalic acid in steps. Ethylene glycol itself can cause intoxication similar to ethanol, but generation of metabolites results in acidosis, cardiopulmonary complications, and renal tubular necrosis. Fomepizole, used in the same manner as for methanol poisoning, is the drug of choice. It is approved by United States Food Drug Administration for this indication and has orphan drug status. Ethanol is employed as an alternative. And the last part of our lecture is examples of MCQs. An anesthesiologist has used nitrous oxide as general anesthetic during operation. This drug has significant solubility in lipids. Indicate the mechanism of penetration of this drug through biological membranes. Of course, if the compound has got significant solubility in lipids, the correct answer will be passive diffusion. To anesthetize the manipulation related to burn surface treatment, a patient was intravenously injected a drug for short-acting narcosis. A minute later, increased blood pressure, tachycardia, increased tone of skeletal muscles, reflexes remained. After awakening, the patient had disorientation and visual hallucinations. What drug was injected to the patient? As you remember, I told you today in the lecture to memorize the idea of hallucinations and by which drug they can be occurred. So the correct answer is ketamine. For initial anesthesia, anesthesiologist administers thiopental sodium to patient. Owing to this, hypersalivation and laryngospasm are developed in patient. Which drug can prevent these complications? As you remember, we mentioned before today, atropine is the drug of choice in this kind of cases. For general anesthesia, anesthesiologist uses combination of inhaled anesthetic and derivative of barbituric acid. Choose this combination. So our mission is to find inhaled one plus barbituric acid derivate. This is very easy because the only barbituric acid derivate in here is thiopental sodium. So option E is the correct option. Acute hepatitis developed in patient after surgery with reuse of some kind of general anesthetic. Which anesthetic drug is used? So we are talking about acute hepatitis, and as I mentioned before, Halotan can cause acute hepatitis. It is specific for this drug. Anesthesiologist administers to a patient general anesthetic with prolonged phase of excitation. Yes, second stage. Which drug is administered? Of course, from all these drugs, the correct one is ether. As we mentioned before, ether causes prolonged phase of excitation or second stage or delirium stage. Disulfiram is widely used in medical practice to prevent alcoholism. It inhibits aldehyde dehydrogenase. Increased level of which metabolite causes aversion to alcohol? This is very easy, as we talked a few minutes ago. Disulfiram inhibits aldehyde dehydrogenase, so it inhibits further metabolism of acetaldehyde. Thank you for the attention.